B.
Yes, 1, 2, and 6. Okay. Which disease should tuberculoma be differentiated from?
Aspergilloma?
All of them, doctor.
All of
All of
them.
them, yes.
Yeah.
So cancer, aspergilloma, cyst, and tumor. Okay.
Cyst and tumor.
Which form of pulmonary tuberculosis is characterized by the presence of thick wall cavity and nodular, infiltrative, and fibrotic changes around it?
Fibrous cavernous.
Cavernous.
Okay, good.
Yeah.
A 37-year-old man is admitted to the hospital because of fatigue, malaise, pain in the left side of the thorax, dyspnea. The symptoms appeared 1 week ago. Body temperature is 38.5 degrees. On examination, shortening of percussion sound, weakening of breathing over the left lower lobe. Chest X-ray shows a massive homogeneous darkening in the left lung from the fourth rib to the diaphragm. The shadow of the heart is shifting to the right. Tuberculous etiology of exudative pleurisy is suspected. Which of the following studies can confirm the etiology of pleurisy?
Investigation of the pleural fluids.
The pleural fluid.
Yes, it's okay.
Fluid, pleural.
Yes, investigation of pleural fluid. Good. Now you, someone of you will have to. Sorry, this is from previous class. We have done it before. This one. A 32-year-old patient comes to the doctor because of fatigue, malaise, night sweating, appetite loss. He had TB contact with his father. Chest X-ray shows shadow of 4 centimeters in diameter of high intensity with clear contours in segments 1 and 2 of the right lung. All the sputum tests for MTB are negative. Which form of tuberculosis do you suspect?
Tuberculoma.
Tuberculoma.
Correct.
Tuberculoma.
Yes, because of clear contours and high intensity. Good.
But 4 millimeter, it's 4 centimeter is not so important as diameter.
Tuberculoma should be more than 1 centimeter. 4 centimeters is more than 1. It's okay.
Okay.
Okay. Because less than 1 centimeter, it is Ghon's focus. That's the only difference between Ghon's focus and tuberculoma. Its size.
Okay.
Okay. This. I wanted to present you my case.
Cirrhotic tuberculosis.
No, this is just infiltrative. Wait a moment. It's not so bad. I tried to treat her. She's not cirrhotic yet. Her lungs are so changed in volume on chest X-ray because she has cerebral palsy and she cannot stand and she cannot lie strictly. She's moving all the time. She is moving her shoulders, and that's why lungs look like different on chest X-ray. But anyway, her lights are almost similar. Okay, I wanted to show you this case as how it can be difficult to make correct diagnosis in patient with, for example, mental illness. Yes, like in my patient. And in cases when you cannot obtain respiratory samples. This is the case of wrong treatment failure, which was thought to be treatment success, but in fact it was failure. And only then, after long investigation, making correct diagnosis and correct treatment. So this is my 51-year-old patient. She has severe mental illness and she is treated in psychiatric hospital. She was evacuated from the north part of Kharkiv region. Psychiatric hospital there was destroyed and she was evacuated in my hospital. When these patients were evacuated, they all underwent medical checkup. Chest X-ray in our country is compulsory for everybody every year. So that we made chest X-ray in this woman and saw this infiltration in the right upper pulmonary lobe. First of all, we could not obtain sputum from the patient. She did not follow the instructions. And she even did not cough normally. I guess problems with cough is due to cerebral palsy. It is hard for she to cough out the sputum. She can cough, but she cannot cough out and to spit the sputum. Okay, so infiltration. First of all, we have provided anti-pneumonic treatment. We used cefepime. We treated her even 2 weeks, not 10 days as usual. However, no improvement was reached, so she was the same. And then I presented this case to Central Doctors Commission, to our council, and they decided that we can treat this tuberculosis without sputum tests. It was also not possible to perform bronchoscopy in this patient, as once again she could not follow the instructions. We thought about the possibility to make bronchoscopy under general anesthesia, but as the mental illness resulted as organic brain damage, we guess, during the delivery of the patient, it was a little bit scary for us to make general anesthesia for bronchoscopy, so that Doctors' Commission decided to start treatment, so that diagnosis was formulated with all the zeros. A new TB of the left lung, of the upper lobe, sorry, of the left lung, infiltrative, destruction minus, and all others are 0. We started treatment as for drug-susceptible tuberculosis, so that intensive phase of treatment included isoniazid, rifampicin, ethambutol, and pyrazinamide. By the way, these dosages are a little bit lower than for all the patients, as this woman had low weight. She weighed only 42 kilograms. She is not high, but she's not tall, sorry. But however, her weight was too low, so we started with lower doses of anti-TB drugs. After intensive phase, she felt better. She became more active. So before this, she was so weak and so depressed. She became more active. Her weight increased by 5 kilograms. However, on chest X-ray, we did not see positive dynamics. It even looked like worse, but if you compare this chest X-ray, there is a little bit different position of the patient, so that we cannot compare these chest X-rays. And the films were a little bit different. However, she had to undergo supportive phase of treatment, so that we sent her for supportive phase. We included in supportive phase ethambutol. Additionally, it can be additional appointment of the third drug can be made by decision of council when we suspect that maybe the treatment with 2 drugs will not be effective enough. So after treatment, we see that the size of lesion is the same, so no resorption of infiltration. It became more intensive. High intensity for TB patients is good. It means fibrosis. It means recovery. But we were a little bit we were very disappointed about the size of lesion, so it did not decrease. However, the patient felt good. She had no cough. She raised weight. She was active enough so that treatment was completed, but Doctors' Council advised us to repeat medical checkup in 6 months. And in 6 months, everything was bad, as in the right lung infiltration spread it to lower lobes, and there appeared new infiltration in the left lung. So during these 6 months, this patient again lost weight, 6 kilograms of weight. She developed cough, and this was cough with hemoptysis, so that it means that somewhere is destruction of pulmonary tissue. It is not well visible behind the infiltration, however, it is present. Pulmonary vessels are destructed. And of course, enlargement of infiltrations. So that it was early relapse of TB disease. Actually, it was not really a relapse because previous treatment was not effective enough. It just stopped development of tuberculosis, but did not cure it, did not treat it. So that doctor's commission advised us to collect sputum sample from this patient. It was not possible to collect respiratory specimens, but however, stool specimens are always available, so that we have obtained the specimen and sent them to the laboratory for expert tests. Expert tests revealed MTB DNA with resistance to isoniazid, rifampicin, and kanamycin. Resistance to isoniazid plus rifampicin, MDR-TB. And that's why we have diagnosed MDR-TB, and we understood why the treatment was not effective. The treatment in intensive phase included 4 drugs and in supportive 3 drugs. 2 of them, isoniazid plus rifampicin, bactericidal drugs, did not work. Another drugs is ethambutol, which was left for supportive phase also, and pyrazinamide in intensive phase. They work, but they are more bacteriostatic, and ethambutol is absolutely bacteriostatic. They just stopped multiplication of mycobacteria, so they did not let them to spread, but they did not kill them also. So when the treatment stopped, mycobacteria started multiplying and involving new pulmonary tissue into the TB inflammation. So the diagnosis was changed as MDR-TB of lungs, infiltrative destruction minus MTB. We suspected that there is destruction because of hemoptysis, but we could not see it, so destruction minus. Maybe we could make CT for this patient, but for nowadays, CT is not well available for civilians, especially, and if you make it in a personal way, it is very expensive. So we did not make CT. However, presence or absence of destruction was not so important, as we understood that the process is large and it requires immediate treatment for MDR-TB. So MTB plus, M0, we did not perform microscopy, molecular genetic plus, RIF plus, drug susceptibility test for first-line drugs plus isoniazid, second-line drugs, kanamycin. Culture was not performed. Phenotypic direct susceptibility test was not available. We did not perform biopsy, and it was in the second cohort of the year. They started BPAL treatment regimen. I asked doctor's commission to make BPAL-M treatment regimen, but their decision was BPAL. They did not explain me why we refused fluoroquinolone, so that I cannot explain you. However, BPAL is also very effective regimen, short treatment regimen, 6 months with bedaquiline, pretomanid, and linezolid. By the way, we choose intermittent intake of bedaquiline. 8 weeks she was taking bedaquiline every day, and then the dose was lower. However, somehow we had to monitor treatment effectiveness. Stool samples are not good for monitoring, as we cannot make culture and microscopy of stool samples. And because of presence of all another flora in the stool. And expert tests are not well for monitoring because they will show MTB DNA, both dead and alive MTB, and we will not be able to know are mycobacteria dying or are they still multiplying and alive? So that for treatment monitoring, which was performed monthly, we made a throat swab collected on empty stomach from the back of the throat. And this material was delivered to laboratory for microscopy and culture. We were not sure will this method work at all, but on the third month of treatment, we saw positive microscopy. It was very lowly positive, so only 5 MTB were found per 100 fields of vision. But however, we understood that this method can find mycobacteria. Well, positive microscopy is not good, but as culture did not grow from this material, it means that all these mycobacteria visible by positive microscopy were dead. So, symptoms and signs of the disease were reduced at the end of the second month of treatment. But only at the 6 months we were available to make a new chest X-ray and to see the result of our treatment. And we see that the left lung, here we see disappearing of infiltration, but in right lung we see high intensive shadow. So there is forming fibrosis. I guess later we will be able to say that there is even cirrhosis of the right upper lobe, but it is still a question for me, what will it be? Will it be just pulmonary cirrhosis, which is of course not good, but actually does not violate life expectancy? Or maybe there are still some mycobacteria which will reactivate and then cause cirrhotic tuberculosis. Of course, it will be worse. However, now the patient is undergoing, well, actually, she's not undergoing treatment. She's living in psychiatric hospital because we don't know how to solve her social problems. However, for now, she feels good. No signs of reactivation. We are monitoring her general state. 3 months later, we will perform chest X-ray and see what happens next. So that's all. Do you have questions?
Or do a sputum specimen or any culture at that time before you went straight to the treatment?
We could not obtain respiratory specimen for her. She did not follow the instruction. She could not spit out sputum. We could not send her for bronchoscopy because of she once again did not follow the instruction, and she had problems because of her cerebral palsy. She had if she is stressed or something, she developed something like seizures. That also made bronchoscopy impossible. We thought about maybe we can do general anesthesia for her to make bronchoscopy, but due to organic brain damage, it was not safe to make it. So that about throat swab, by the way, we could do this, and but we. I don't remember. I guess it was not in our orbit at that time, so we did not know that we can do it. By the way, later on next classes, I will show you another case, very similar to this, but there was pleurisy. So in that case, at the moment when we thought about multi-drug resistance, we made 2 analyses simultaneously. Throat swab and stool. And experts showed MTB in stool, but did not show in throat swab. Yes, it's due to maybe concentration of MBT there and there. Okay, more questions? It is more standard regimen, yes, but it is more standard for pre-XDR TB, for those who are resistant to fluoroquinolones.
Yeah, for me,
MDR-TB, it was more it was logically to add fluoroquinolone as she's susceptible to them. But I don't know why did not they add the fluoroquinolone in treatment regimen. I'm not sure
Yes.
about this reason.
Yeah, my question is why the pretomanides? Yeah, because
Britomamide,
It's just-
yes, it is the newest anti-tuberculosis drug. It's very effective. As it is the newest, there is still no resistance to it for now. And it is very effective in this combination. Actually, this combination together is absolutely bactericidal.
okay.